Everyone always thinks that they have unique sins, unique wrong answers, unique defects, and it's not true. Our defects and our weaknesses and the things that we get wrong are absolutely predictable. It is good to be predictably wrong so you can be wrong now. What I'm going to show you is a sample across multiple disciplines of our Step 2 USMLE video course so that you can learn what some of the most common wrong answers are, and so you can learn that you're predictable in them. No one, if their car was broken, would want a person who said, "Oh my God, what's in there? Man, I don't know what's wrong with that car. Could be anything. Maybe the engine will explode." No, you want to be able to say, "Listen, no. What you have is a mistake, or what you have is wrong, is what everybody always has wrong." And we can predict these things. Now, I can't predict your virtues. What we love is unique. Who would know what we love? Each individual. But to know the things that you're going to get wrong before you get them wrong on test day is critically important. So let's take a look across and say, hey, we got a man who comes to the emergency room with a fever and a headache, and a headache and a fever, and a fever and a headache and a stiff neck. Now, they could ask you from this question, what is the most likely diagnosis? They could ask you from this question, which physical findings is most likely to be found in this patient? Untreated, what's the most common complication of this? Eighth cranial nerve deficit. Why does it burn the eighth cranial nerve? Nobody knows. We could ask you what the best initial test is. We could say blood cultures. We could say, what's the most accurate test? A lumbar puncture. Or we can say, what would you like to do next? Now, when a question on Step 2 says, what would you like to do next? Now, when it says next step, action, do, management, step, action, do, management, does that mean a test or a treatment? The answer is it could be either one. And that's the fundamental question for you on your test, is to know the order in which to do things, to choose. You are presented with a choice of life or death, therefore choose life. And in this case, what would I do next? I have some tests, I have some treatments. Well, this guy definitely needs a head CT. He definitely needs a head CT, and a head CT is good, but empiric treatment is gooder, because this person seems to have pretty clear meningitis, fever, headache, stiff neck, photophobia. If I told you it was acute, it would be even more like bacterial meningitis. Because there's focal findings, sometimes papilledema, severe confusions, focal findings, papilledema, confusion, you need to do a CT before you do the lumbar puncture. If you do a lumbar puncture on a man with herniation, you could end up going, ooh, lumbar puncture on this man will cause herniation. You go, what's that I feel in your rectal exam? That's a nice smooth prostate. And you go, that's not my prostate, that's my pons. So when you have a delay to lumbar puncture, you must give empiric antibiotics. But Dr. Fischer, won't that make our lumbar puncture less accurate? Yes, but it's better to be alive with an inaccurate lumbar puncture than to have irreversible brain damage and death with an accurate LP. This question is a perfect example of a Step 2 question for you, where you have to choose test versus treatment. And don't they all look partially good? Yes, they do. 64-year-old man had an inferior wall myocardial infarction last night, and now he's confused. Of course he's confused, because he's hypotensive. Blood pressure is really low. Pulse is 45. Canon A waves. Canon A waves is atrial systole against a closed tricuspid valve. So it bounces backwards up in your neck. It bounces backwards up in your neck. Atrial systole against the closed tricuspid, pounces into your neck. A 3/6 systolic murmur radiating to your axilla. Ooh, that's mitral regurgitation. Now this question could say, what is the most likely diagnosis? The question could say, what is the best initial test? What is the most accurate test? What is the best initial therapy? What is the most effective therapy? How do you know which of those questions you're going to get? You don't. So the person who does well on USMLE is prepared for all of them. So you, when you get to test day, don't have to worry, hey, let me give you the one test question that was there. You go, no, I know all of them. Most likely diagnosis, best initial test, most accurate test, best initial therapy. In this case, you're getting asked, what's the best initial therapy? The best initial therapy, well, I will tell you, the most common wrong answer is pacemaker. The most common wrong answer is a pacemaker. But he needs a pacemaker. He does need a pacemaker. He needs a pacemaker because he's got symptomatic bradycardia. And not just any symptomatic bradycardia, he's got, most likely diagnosis, 3rd degree or complete heart block. Bradycardia, hypotension, canon A waves. Bradycardia, hypotension, canon A waves. How did 2 guys named Stokes and Adams in 1825 and 1848 describe complete or 3rd degree AV block 50 years before Einthoven invents the EKG? Because they were called to see people that they thought had seizures. Because hypotension and confusion can look like a seizure. And what they saw was slow heart rate, disorientation, and canon A waves. The best initial test, of course, is an EKG. The most accurate test is electrophysiology studies, when you sometimes do have to do that to find an etiology of your cardiac arrhythmia. The most effective therapy is definitely a transvenous pacemaker, but the first thing to do is atropine. Now, somebody always goes, but sometimes it doesn't work. It doesn't always work to speed the heart. It might not always work. And you cynical person, you, atropine is like true love. Just because it doesn't always work doesn't mean you shouldn't try it first, because it might work immediately and make you feel much better. Then they need the pacemaker too. Most likely diagnosis, best initial test. EKG, most accurate test. EP study. Atropine is first and pacemaker later. What is this? This is a person who has cape-like distribution. Cape-like distribution across their back, across their back. They have numbness, they have tingling, they have loss of pain and temperature, and a cape-like distribution across their back. What is the difference between saying a bubble and a syrinx? The answer is $50,000 a year in tuition. Yes, it's a syrinx. It's a bubble in my spinal cord, and it rips the fibers as they cross, as they decussate across the spinal cord, pain and temperature going across. You could be asked this image. That's a strange image, yes, but you can be asked that image and say, what is that? Or get a brief case history and say, what is that? Here's a simple, straightforward question on cancer screening. Except it's not just any question, it happens to be the single most commonly asked question about cancer in the whole test. Because you know, they don't ask you a lot of specific chemotherapy on step 2. They're not going to ask you carboplatin, oxplatin, visplatin. They're not going to ask you all the million chemotherapies and biological agents for, say, something like a lung cancer, because that's not your question. The general doctor is not deciding on specifics of chemotherapy with specific solid organs, but everybody's supposed to be screening. Which cancer screening lowers the mortality the most if you screened 1,000 people? The most common wrong answer is pap smear. Try it again. The second most common wrong answer is colonoscopy. The right answer is mammography above 50. If you screen 1,000 women with a pap smear, you will find much less cancer than screening 1,000 women above the age of 50 with mammography. Pap smears have been extended to every 5 years with HPV testing, or HPV testing every 5 years alone. HPV vaccine is going to make 90% of cervical cancer extinct. There's only 9,000 or 10,000 cases a year in the whole country, but there's 250,000 cases of breast cancer. Straight on ahead question. You can't remove the cancer unless you find it. Now, you notice the question doesn't say, when should you begin? Because people always say, hey man, what do I do about competing guidelines? What do I do about one organization says 40 and another organization says 50? And the answer to that is that USMLE is not going to play a game with you. They're not going to ask you about competing guidelines. They're going to ask you what everyone would agree on. It doesn't say when to start. It says when's the greatest benefit. Mammo above 50. Now, neurosyphilis. Well, they all look so good, don't they? Aren't they all partially right? Most sensitive. Negative test rules it out. Snout. A negative test rules it out. Snout. sensitive. Sensitivity statistics means if you have the disease, how likely are you to have a positive test? If you have the disease, how likely are you to have the positive test? The most common wrong answer is dark field, because that's the penis, and this is the brain. Penis, brain. Next, second most common wrong answer is an RPR or a VDRL. The VDRL and RPR, which are essentially interchangeable, are only 50% sensitive in neurosyphilis. RPR and VDRL are sensitive in blood, but not in cerebrospinal fluid. In cerebrospinal fluid, the FTA, fluorescent treponemal antibody, the girl from Treponema, is 99% sensitive. Little bonus point, extra bonus point for the brand new car in the dream home in Boston. If you're penicillin allergic, what do you do for a syphilitic chancre? Syphilitic chancre, genital. If you're penicillin allergic for genital, the most common wrong answer is desensitize. The most common right answer is doxycycline. You desensitize for neurosyphilis, not for genitals. Raise your hand. I promise, I promise, I promise never, I promise never, I promise never to desensitize genitals. But desensitize neurosyphilis in pregnant women, they're too sensitive anyway. What is this? Is this a Greek man who goes to a Greek restaurant? He has prima queen as an appetizer, fava beans as main course, and dapsone for dessert? Yeah, no. The most common cause of oxidant stress in G6PD, Heinz bodies. Looks like a smile, doesn't it? The most common cause of oxidant stress in G6PD deficiency is infection. And these Heinz bodies, not visible on regular blood smear, but they're visible on a special supravital stain. And those Heinz bodies go to your spleen, and that spleen goes there and doesn't like that Heinz body, so it takes a bite out of your hiney. The Heinz bodies get bitten out into bite cells. G6PD. What is the best initial test? This is a person who has low back pain radiating to his buttocks for 2 years before he's diagnosed. Restrictive lung disease because his ribs do not move. Schober does not bend over. Schober does not bend over. This is the best initial test for ankylosing spondylitis. What's the most accurate test? Most accurate test is an MRI. What's the most common wrong answer? HLA-B27. HLA-B27 is not a diagnostic test. Now, here's a Conrad Fischerism. Here's part of the Fischer method. Questions are numberless, but answers are limited. So let's work backwards from answers. So it goes like this. When is HLA-B27 the answer? It's the answer when it says equivocal MRI. Typical symptoms, man in his 20s and 30s, 2 years delay with back pain going into the buttocks. Negative SI joint, equivocal MRI, that's when HLA-B27 is the answer. The best initial therapy for HIV. HIV is very easy. One of the things we do for you here in these videos, and of course the world's best-selling Step 2 USMLE book, is to make sure that we don't tell you more than you absolutely have to. And you don't have to know a lot about HIV anymore. It's pretty simple. You treated any T cell, almost any viral load, any T cell count. And the best initial therapy is 2 nucleoside reverse transcriptase inhibitors and 1, most common wrong answer, protease. Right answer, integrase inhibitor. Protease inhibitors are not the best initial therapy. They have more adverse effects and less efficacy. Now, one of the most important things about Step 2 is to know the order or sequence in which to do things. You're presented with history, physical labs. They could say, what's the best initial test or treatment? But they also say, what would you do first? Critical. So Step 2 actually can have a smaller knowledge base than some parts of Step 1, but the harder part is clinical judgment. What to do? 54-year-old man who's tired. He's in the ED? No, he has erectile dysfunction. His skin is dark, bronze. Transferrin saturation, best initial test for this, which is a high iron and a high ferritin, high iron and a low iron binding capacity. He's got liver dysfunction. What test will confirm the diagnosis? Oh, you get diabetes. Oh, yeah, MRIs pick up iron. Yeah. Oh, liver biopsy, that tested. Oh, Prussian blue. Prussian blue is the iron stain. That is this iron stain. Oh, giving deferoxamine and deferricerox to see if it dislodges iron. Oh, they all look partially right. And that's one of the things you have to expect about step 2. You have to expect that most of the wrong answers look partially right. What would you do next to confirm the diagnosis is the abdominal MRI looking big iron built up in the liver and the HFE gene. What's that like? That's like human iron. So they could have asked you, what's the most likely diagnosis? Hemochromatosis. What's the best initial test? It's in the question. What's the most accurate test is a liver biopsy. What's the best initial therapy for hemochromatosis? Most common wrong answer, deferoxamine. It's phlebotomy. Not phlebotomy, phlebotomy. What's the most common cause of death in hemochromatosis? The most common wrong answer is cardiac. Cardiac is the most common wrong answer. The right answer is cirrhosis. 60% cirrhosis, 20% hepatoma. But I know why people would say cardiac, because there's not that many things that cause restrictive cardiomyopathy. What causes restrictive cardiomyopathy besides sarcoid, amyloid, hemochromatosis, cancer and fibrosis, sarcoid, amyloid, hemochromatosis, cancer and fibrosis as restrictive cardiomyopathy. Be wrong now. When is psychiatric consultation the answer for toxicology? I don't need a psychiatrist. I don't need a psychiatrist to tell me to give charcoal and N-acetylcysteine for aspirin. I don't need a psychiatrist to tell me to alkalize the urine for aspirin overdose. I don't need a psychiatrist to tell me to check the EKG for tricyclics. Wide. Check the EKG for tricyclics. Wide QRS. I don't need a psychiatric consultation. Oh, in life, get a consult. You got to get a consult. You got to get a consult. On step 2, no, you're supposed to know what to do. You're not supposed to need consultants for cognitive skills, ladies and gentlemen. 34-year-old woman with face pain, teeth pain, fever. It's a fever. It's the bad taste in the back of your mouth because the bitter taste receptors are on the back of your tongue. Part of the gag reflex. Cranial nerves 9 and 10. Discolored discharge and a fever. So they could ask you the most likely diagnosis, but I don't think so. I think Helen Keller could get that diagnosis. You're going to do the discolored dispersion of pain. What's the best initial test? What's the most accurate test? What's the best initial therapy? Now the question doesn't say what's the therapy or what to do. If the question was what to do, the answer would be amoxicillin, clavulanic acid, and decongestant. But the question didn't say what to do, did it? Your mind, our minds change the question. Our minds change the question. The question doesn't ask you the diagnosis. It's sinusitis bacterial. How do I know it's bacterial? Because it says discolored nasal discharge and a fever. The question doesn't say what's the best initial test. The question doesn't say what to do because I don't have to do any tests in this really obvious diagnosis. Our mind sometimes changes the question from what it's asking to what you want to answer. And I want to answer what to do next, which is go straight to treatment. But that's not the question, is it? Which of these is most accurate? The most common wrong answer is CT scan. The right answer is to biopsy. What? I never saw anybody get biopsied. Yeah, oh, well, it can't be right then because you never saw it. Ugh. Yeah, but it says most accurate. Now, the best initial test is a CT. X-rays are out. Could be a CT or MRI, but it says most accurate. Somebody gets treated and they recur, and they treat it and they recur. You treat and recur, you treat and recur, you don't get better. You treat and recur, or you didn't get better. That's when biopsy is the answer. Now, if you have recurrences, maybe you have a fungus in there, maybe you have a multi-resistant organism, maybe you have a nasopharyngeal carcinoma, I hope not. But I've seen aspergillus sinusitis. I've seen mycobacterial sinusitis. And you don't know unless you biopsy if they recur, or don't get better. Here's a general principle. Dr. Fischer, listen, I don't really want to learn very much. I just want psychiatry in Saskatchewan. So I'll give you like this. Ready? How do you answer the infectious disease questions? The radiologic test is never the most accurate test. A radiologic test is never the most accurate test, not for infectious diseases. You cannot stain a CT. You can't culture an MRI. You can't get sensitivities on a nuclear scan. So if it says the most accurate in infectious disease or malignancy, it's biopsy. Cryoprecipitate. Well, you know why I've got this like this? Because we want to be able to just say, look, dude, I can't remember this much. I know you want me to read, watch, read. I'm lucky if I can read half and watch half. Just make it easy for me. When is it the answer? Okay, let's work backwards from answer, because as we said, there's a lot of questions, a limited number of answers. Cryoprecipitate is pooled plasma proteins, pooled blood, clotting factors. It's basically fibrinogen. It's never first for anything. Never first for anything. Then when is it the answer? It's the answer for DIC when you want to give a lot of fibrinogen and somebody just won't stop bleeding with their FFP. That's when it's the answer. Never first for anything, giving fibrinogen and DIC. Warfarin bleeding. Warfarin, I've got warfarin and I've got a INR of 10. And I've got a high prothrombin time, and I'm bleeding, bleeding, bleeding. It's reversed with, most common wrong answer, fresh frozen plasma. The right answer, prothrombin complex concentrate. And sometimes people come up and say, it can't be the answer because I never heard of it. Prothrombin complex concentrate is a concentrate of the vitamin K dependent clotting factors 2, 7, 9, and 10. 2, 7, 9, and 10, and sometimes protein CNS. It's the treatment for reversing warfarin, and FFP is not the answer. First of all, it doesn't transmit disease. Second of all, it's at room temperature. Third, no volume. You don't have to worry about excess volume, and it reverses only the clotting factors you need. When is whole blood the answer? Yeah, I can't stand it. Just give me the answer. The answer is never. We either use fresh frozen plasma or packed cells. So you like answers like this because you walk in on test day and Dr. Fischer told you it's never the right answer. So it's a choice. You love it because you just now win at 4 choices. What's the most common adverse effect of statins? Atorvastatin, pravastatin, simvastatin, rosuvastatin. The most common adverse effect is, well, muscle rhabdomyolysis is the most common wrong answer. The right answer is liver. Liver is 10 to 20 times more. Be wrong now when it can't hurt you. Here's what's the most common cause of blindness. It's not very important. It's just blindness. What does it matter? If you don't know the most common cause of blindness, doesn't matter. The most common wrong answer is diabetes in adults. It's not. We're doing so well. It's not. The right answer is macular degeneration. But after all, what can you do for macular degeneration? And the most common answer is nothing. And that is wrong. And the right answer for macular degeneration, because which one makes you blind more, is the wet macular degeneration. The right answer is VEGF inhibitors. Ranibizumab, bevacizumab stops 97% of wet macular degeneration and reverses a third. Reverses it? Restoring sight to the blind with VEGF inhibitors? You have the power to restore sight to blind people? To raise the dead with an implantable defibrillator? 90% less people in psychiatric hospitals compared to 40 years ago. And leprosy can be cured for $1 or $2's worth of dapsone. You have miracles in your hands. You can reach up into a brain and snatch a clot out hours after the time limit for thrombolytics. Go up to 24 hours and snatch a clot out. You can stop all HIV, restore sight to the blind, cleanse lepers, raise the dead, restore sight to the blind, cast out psychological demons. What a miraculous time. How lucky we are to be alive right now. And some of you may look at hatred and negative speech and bad things that people say that are so rejecting of parts of our population, those fellow sacred, precious human beings, and say, how can we live when people say these things and treat people this way? And I will tell you what my message is to you. That negativity is the last gasp of hatred from people who are clawing their way to just try to stay in power. And what we're going to do is learn to love to be wrong so we could be right on our test, right for the residency program directors you're going to see, and right for our patients, because we're making a better world and we're filled with knowledge, love, and goodness.